All right, I have 12 o'clock, so we'll go ahead and get started. I want to welcome everyone today to Medical Grand Rounds at the University of Colorado. I am really pleased that we are back in person. It's fun to talk to a room full of people. And so I'll just remind everyone for the first few sessions that we are doing this as a hybrid, although we're encouraging everyone to come in person this year for at least as long as we can do this safely. And so we are on the second floor of RC2 in Krugman Auditorium. We have once again have a almost 100% packed room, but you are welcome to come. We'll get more chairs and lunches as needed. Upcoming talks, I just want to let people know what's coming for Grand Rounds in the next few weeks. On August 24th, Dr. Amberdecker from our own cardiology division will be talking about cardiac amyloid, which should be an excellent talk. He is a world-renowned expert. And then on August 31st, we have a very special Grand Rounds. Dr. Andres Hanau and Dr. Karen Wendell from the Department of Infectious Diseases are going to give a special and timely talk on monkeypox and what it means and this new emerging epidemic. So I want to also announce that we're pleased to once again offer CME and MOC credit for all Grand Rounds this year. If you were to attend all Grand Rounds, that would be your MOC needs for your career. And so please do come. Please use the QR code that we have on the beginning slide here, or the one that was sent to you in your email if you're watching this talk on Zoom. And then just a reminder that questions this year will come primarily from our live audience, but also using the Zoom Q&A feature. The chief medical residents are here. They'll monitor the Zoom Q&A. And so if you have questions that you would like to put in online, please do so. And now I am pleased to welcome today's speaker, Dr. Manali Kamdar, who is an associate professor of medicine here at the University of Colorado, Department of Medicine in the Division of Hematology and Oncology. It really is an honor to have you here today. She is a graduate of Somaiya Medical College in Mumbai, India. She then came to the United States to attend internship and residency at East Carolina University. She did her internship there, her residency, as well as her fellowship training in hematology and oncology, where she served as chief fellow. And this was the start of a very long career of successes, which led to her coming to the University of Colorado in 2014. She also, between East Carolina and here, did a bone marrow transplant fellowship at Stanford University for 1 year. And we were lucky, as I said, to recruit her here in 2014, and she's been on faculty at the University of Colorado since that time. She came in as the clinical director of lymphoma services, and then in 2019, it had the title added as she was appointed the immunotherapy lead for lymphoma at UCH. Dr. Kamdar is nationally recognized for her work, having spoken over 50 times just in the last couple of years on topics of lymphoma and advances in lymphoma therapy. She is the author of over 75 abstracts, chapters, and original manuscripts regarding her work in the same fields. She is on the NCCN guideline panel as a member of the CLL, SLL, hairy cell leukemia committee. Dr. Kamdar is currently the lead PI on 5 different trials here at the University of Colorado, including several on CAR T therapy for lymphoma and others on monoclonal antibody therapy for the same disease. And so we really are lucky to have a national and an international expert to talk to us about immunotherapy and lymphoma today, Dr. Kamdar.
Thank you so much, everyone, for this very kind invitation. And I'm so excited to talk to you about immunotherapy in lymphomas, what the present holds and what the future holds. This is my statement of disclosure. And you may say this is my soapbox, but this is important to really highlight before we really deep dive into immunotherapy. Lymphoma is the most common blood cancer. About 85,000 patients every year are diagnosed with lymphoma. So clearly, the incidence is high, and because we are doing well, the prevalence is high. It's extremely important to understand that this cancer, in terms of staging system, we do not use the TNM staging, barring a few lymphomas. Most of the lymphomas follow what we call the Ann Arbor staging. Really very important to get the adequate biopsy for diagnosis. And I cannot harp on it several times over. And FNA is absolutely unhelpful for patients to get a diagnosis of lymphoma. As you can see on the right diagram here, if you have a fine needle aspirate, all we get is either small cells or large cells. We cannot make any further testing based on an FNA. As a result, excisional biopsy is the gold standard to make a diagnosis for lymphoma. And if it's at a site which is dangerous to really proceed with a surgical biopsy, then multiple core biopsies is what we would need to make an adequate diagnosis in order to get the patient to the best therapy. In terms of tumor response assessment, you may have heard in our progress notes talking about lymphomas that we use a system called the Lugano-Doval scoring, and it's usually for most of the common lymphomas, which are on a PET scan FDG avid. PETs are considered standard of care for patients with aggressive lymphoma, and we need a PET scan at diagnosis for tumor response assessment and at the end of treatment. It is way better in terms of sensitivity and specificity as compared to a CT scan. So, with that, I'll move forward to the classification of lymphoma. The reason behind this is not really to have you look into the different subtypes, but I really want to underscore the fact that every 2 years, the WHO comes up with an additional classification where there is addition of multiple subtypes. And if you were to count those, there are nearly 85 different subtypes of lymphomas. And as you can imagine, their treatment and management is fairly nuanced. In terms of how I look at it, I like it simple. It is a heterogeneous group of malignancies, but broadly speaking, divided into either Hodgkin lymphoma, which is rare but the most curable, versus non-Hodgkin lymphoma. Within non-Hodgkin lymphoma, it's further subdivided into B-cell non-Hodgkin lymphoma, which makes up the majority of the incidence of non-Hodgkin lymphoma, which is further divided into either aggressive lymphomas that are fast growing, patients need intensive chemotherapy, attention right away, but about 50% of them can actually have a cure with frontline chemoimmunotherapy. Then you have the indolent lymphomas, which are slow chronic diseases. The philosophy of care is to really not do too much unless and until it's truly needed. And this is where we could go from watch and wait to antibody treatments to sometimes even chemotherapy. And then there is a very small bucket called the mixed lymphomas, where they initially present in a non aggressive way, eventually going into an aggressive biology. And then we do need to modify our therapies and treat them intensively. The second bucket within non-Hodgkin lymphoma is called the T-cell non-Hodgkin or NK cell non-Hodgkin lymphoma. Dr. Brad Haverkost within our division leads the T-cell non-Hodgkin lymphoma program. It makes up for only 10 to 15%, but I will tell you, there are very few experts in the world, and I will have to say that based on all the research and everything that he has done so far, after 2015, he is now on the NCCN panel and doing amazing stuff within this subtype, which is actually doing a way better than what it used to even 5 years ago. In terms of the tools that we have for treating lymphomas, if you look at the age-old concept, we either had radiation or chemotherapy. Clearly, chemotherapy kills the fastest growing cells of the body, which include the cancer cells, but it happens at the cost of normal fast growing cells of your body. And thus, the myriad side effects that we have to really assess in terms of chemotherapy administration. Surgery can never treat lymphomas. As a result, chemo and radiation has been the age old concept. But when you go into the new concept, immunotherapy has certainly been a huge, huge step forward in terms of the modalities of therapies that are available for treating lymphomas. Clearly, immunotherapy has unleashed upon us in a variety of cancers, especially in lymphomas. It has certainly taken some of the subtypes with very poor, dismal prognosis to now curable outcomes. In terms of what we really manipulate is the immunities in terms of the two distinct immunities that we have in terms of innate or adaptive. Innate immunity kicks off within 6 hours. On the other hand, adaptive kicks off in a few days but has memory. So far, all the immunotherapeutic modalities that are currently either FDA approved or on clinical trials are really using the adaptive immunity in order to manipulate and effectively kill tumor. In terms of immunotherapy, it has rapidly evolved over the past 1 decade, but it took several decades to actually make a difference. For example, the oldest immunotherapy has been allogeneic transplant. And I will say in the world of lymphomas, the incidence of allogeneic transplants is steadily going down thanks to a lot of other immunotherapeutic therapeutic modalities that are not only more efficacious, but also less toxic. So, what am I going to really touch on today are these 5 key topics in terms of immunotherapy usage in lymphomas. Let's start off with monoclonal antibodies. This is something that the audience is, of course, not foreign to. We use it in several other specialties, but the idea is to really use the CD or the cluster of differentiation markers that are expressed on a B cell or a T cell and then develop a monoclonal antibody against it. Rituximab has been the poster child for many, many diseases, especially B cell non-Hodgkin lymphoma, because B cell expresses a CD marker called CD20, and rituximab is a monoclonal antibody that sits on this marker and then expresses its cytotoxic ability, even in the form of ADCC, which is antibody-dependent cytotoxic activation, complement activation, as well as direct apoptosis. Clearly, rituximab has been the backbone of B-cell lymphoma therapy for many, many years. And in the world of diffuse large B-cell lymphoma, which is an aggressive lymphoma, makes up for 30% of all non-Hodgkin lymphomas. And with upfront R-CHOP, you are able to cure at least 50% of patients who have a new diagnosis of diffuse large cell lymphoma. Anything in oncology that improves overall survival becomes the standard of care overnight. And this is very nicely demonstrated with this Kaplan-Meier curve, which actually shows you that CHOP versus R-CHOP, if you add the Rituxan, you will actually do better in terms of survival. What about the indolent lymphomas? Has it been effective in indolent lymphomas? And it has. Remember, patients with indolent lymphoma have a very long lifespan. And in order to determine overall survival benefits could be a very uphill task. As a result, a surrogate endpoint has been what we call a progression-free survival. And if the progression-free survival, meaning you're able to keep patients in remission for at least 3 or 4 years longer than someone who doesn't receive that therapy, you probably have a good way to get a recommendation to use that treatment. And that's exactly what this shows. In patients with follicular lymphoma, often we use something called watch and wait. And this was a study that compared watch and wait to rituximab maintenance after initial chemoimmunotherapy. Rituximab maintenance was able to keep patients progression free at least 50% of the times at a decade mark. As a result, a lot of patients with indolent lymphoma, especially follicular lymphoma, could be getting maintenance rituximab every 2 months for 2 years. So what have we done with regards to monoclonal antibodies? Have we done better? In terms of multiple clinical trials that were testing multiple monoclonal antibodies that target CD20, these are the 3 that eventually made it to approvals. Ofatumumab is typically not used in the US, but it is used in the EU. On the other hand, obinutuzumab is a type 2 antibody, and the structure is devised in such a way that the mechanism of action concentrates on the fact that it has a higher ADCC and a higher direct kill versus complement-mediated cytotoxicity, which is slightly higher with rituximab. Obinutuzumab has actually shown to have improved overall survival in patients who get CLL. So in a lot of CLL patients, chronic lymphocytic leukemia patients, we use obinutuzumab as frontline treatment. Moving forward, what can we do to these antibodies to make them more effective and hopefully be able to only engage in cancer cell kill and spare the normal cells? And this is where the antibody drug conjugates come into being. These are also called, in my opinion, empowered antibodies. As you can see, you are able to attach with the modality of a linker a cytotoxic agent. And this is an antibody drug conjugate. It's not chemo-free. You are delivering chemo, but you're delivering chemo only to the cancer cell. So you can then imagine the myriad possibilities that can arise as long as you know the cancer cell that expresses a certain CD marker higher than the other subtypes of lymphomas. What does this antibody drug conjugate do? So the ADC in the plasma binds to the antigen receptor of importance. For example, in T-cell lymphomas, we target CD30. In Hodgkin lymphoma, we target CD30. In non-Hodgkin lymphoma, we target something called CD79B. The ADC binds to that receptor, gets internalized, and then releases a cytotoxic agent. Herein, for example, in brentuximab or polatuzumab, the cytotoxic agent is called MMAE, and then causes tumor kill. So in terms of some of the data that looks promising and has led to FDA approval, brentuximab is a CD30-directed ADC that did show really excellent responses in patients with relapsed Hodgkin lymphoma. Now, a lot of people would say Hodgkin lymphoma is so curable. Why really bother about relapse? Well, I will have to say those are the good risk Hodgkin. The high risk Hodgkin lymphomas still have about a 20% chance of a relapse. And those are the patients who are young or either very old. As a result, we want to make sure that we give them that second shot at a cure. So within the concept of relapse Hodgkin lymphoma, we also know that the Reed-Sternberg cell expresses a CD marker called CD30. And in patients with relapse Hodgkin, brentuximab in a clinical trial of about 100 patients showed that nearly 32% of patients underwent a complete response, which was durable. So anything that does that well in oncology gets moved on to the frontline setting. And over a period of time, Echelon 1 was designed. Echelon 1 was designed with the idea of challenging ABVD, which has been the age old way to manage Hodgkin lymphoma. However, bleomycin that contains in ABVD can cause pulmonary toxicity. And in order to mitigate that, the idea was to involve another agent instead of bleomycin. And that's where they chose Adcetris, also brentuximab. So AAVD for 6 cycles was compared to ABVD in a really large phase 3 randomized study of almost 1,300 people. And at this point in time, very happy to let you know that not only was it statistically significant and superior as compared to ABVD with regards to progression-free survival, but also 41% chance of reduction in death and thus improved overall survival. Thus, if today a patient walks into my clinic, just about 5 years ago, I used to do ABVD all the time, but now the standard of care would be AAVD. Similarly, the polatuzumab story, which is an ADC that binds to CD79B with the idea of releasing the cytotoxic agent, which is MMAE. MMAE-based ADCs can cause neuropathy, can cause neutropenia, can cause severe constipation. So these are some of the side effects that you do have to be mindful of and do appropriate dose reductions or dose holds. And this was the first study that I opened when I started here at the University of Colorado. And I'm very happy to report that it was a positive study. This was a study in patients with relapsed refractory follicular and diffuse large B-cell lymphomas. In diffuse large B-cell lymphoma, the comparator arm was bendamustine rituximab. There's not really a lot available about in 2015. As a result, it was a reasonable comparator. And the good news is not just the progression-free survival, but also the overall survival was statistically significant and superior as compared to the control arm. And thus, polatuzumab plus bendamustine rituximab became FDA approved for patients with relapsed diffuse large B-cell lymphoma. Moving forward, let's start off with a case. The 70-year-old patient, excellent performance status, comes in with palpable inguinal lymph nodes, got a biopsy, excisional biopsy revealed a diffuse large B-cell lymphoma. FISH showed a normal risk diffuse large B-cell lymphoma. Labs revealed an elevated LDH that basically makes his IPI score, which is the International Prognostic Index score, of 2, considering age over 65, and elevated LDH will assign him 2 points. So which regimen would you choose to treat this patient? And I will just go ahead and give you the answer in terms of what we chose. 3 years ago, we chose R-CHOP ×6. R-CHOP has been the standard of care in frontline diffuse large B-cell lymphoma for over 2 decades. And there have been multiple attempts at improving R-CHOP because we do know that a handful of patients, nearly 40 to 50% of patients, will initially respond to relapse later or not respond at all. So intensification, giving it more frequently, giving it with an infusional backbone, giving it with a different monoclonal antibody, giving it with an autologous bone marrow transplant, and multiple other studies were all negative. So R-CHOP continued to be ruling the roost for about 20 years, up until last ASH. And this is where the POLARIX study was presented. And POLARIX was a randomized phase 3 study which compared patients who had a high-risk DLBCL, which was an IPI of 2 or over, and randomized them to either R-CHOP, which is the standard, versus polatuzumab plus R-CHIP. They could not do pola plus R-CHOP because the O, or the oncovin, or the vincristine, also can cause neuropathy. And as you No, with polatuzumab, neuropathy can also happen because of the MMAE construct. And this study, at a median follow up of about 2.5 years, was a positive study, met its primary endpoint of progression free survival. Pola R-CHP significantly improved PFS compared to R-CHOP. At this point, we are awaiting FDA decision. So the next month, maybe if we get that decision and it becomes the new standard of care, you'd probably see us do a lot of Pola R-CHPs in our clinic. Moving forward with regards to checkpoint blockade, and I'm certain that some of my solid tumor experts have also talked about immune checkpoint blockade, but in the world of lymphomas, it also works. And as you know, in order for T cell to perform its effective function, we need two signals. The first signal is when the T cell receptor binds to the antigen that is brought in by the APC, which is MHC class 1, and that is the first signal. However, in order for the T cell to really be able to perform its function, it needs the second signal. And the second signal comes in the form of the co-stimulator signaling, wherein CD28 on the T cell binds to B7-1 and B7-2 on the APCs, and that actually leads the T cell to cause cytotoxicity. Clearly, ongoing cytotoxicity without a checkpoint will basically lead to an autoimmune phenomena within the body. As a result, this needs to be regulated by checkpoints. And we have a central checkpoint and we have a peripheral checkpoint, and we have multiple of those. But the idea of these checkpoints, for example, CTLA4 or PD1, is to hush the T cell and basically say your job is done and now move on. In terms of the targetable immune checkpoints, then you have a plethora of options. You can either activate the stimulating checkpoints or you can inhibit the inhibitory checkpoints. The most what we know so far in lymphoma is that immune cells are prevalent at sites of lymphoma, but they do not eradicate it. Increased regulatory T cells are present in lymphomas, and this is usually of the exhausted phenotype. Cytokines can induce T cell exhaustion, and increased PD-L1 and L2 expression can happen in certain lymphomas. However, as opposed to solid tumors, we don't typically stain lymphoma cells with PD-L1 and L2 to assess if they're going to be helpful. The one pathway that has been explored in lymphomas is the PD-1 PD-L1 pathway. And this is the pathway wherein we now have two drugs that are FDA approved, nivolumab and pembrolizumab, which are PD-1 inhibitors that basically cause T cells to continue the stimulation and thus tumor kill. And this is the single agent activity of PD-1, PD-L1 axis across all relapse refractory cancers. And I will have to say that lymphomas rule the roost here. They have the highest amount of response with a PD-1 inhibitor. In terms of the existing available data, we do know that patients who did get PD-1 inhibition had an excellent response if they had relapsed Hodgkin lymphoma. When you see a waterfall plot like this, you do know that the drug is a winner. The one thing that I will have to highlight is this is excellent. The overall response rate is upwards of 80%, but the complete response rate is only 20%. And we don't quite know why the CRs are low in patients with lymphoma, especially when the response is so high. This is one of my patients reproduced with his permission, 35-year-old male with Hodgkin lymphoma, really blown through 5 treatments. All of them were cytotoxic agents, including brentuximab. And this patient got a checkpoint inhibitor. I gave him pembrolizumab, and he had a complete response at the day 90 mark. He continues to be in a complete response. And at this point, after 2 years of pembrolizumab, he's off of treatment. So the overall experience with immune checkpoint blockade has been about nearly 500 patients have now been treated. We don't quite know why the CRs are this low. It could be a function of how we actually do response assessment. PD-1 inhibition can cause a lot of false sensitive uptake on a PET scan, and that's something to consider. Median duration of response beyond stopping treatment has been over a year, which means that the switch once turned on will hopefully remain turned on. The major side effects that you have to look out for is itises. So any of those, thyroiditis, hepatitis, could be diarrhea, it could be pneumonitis. patients who have a lot of fatigue, that's their only symptom coming on an immune checkpoint blockade, you need to check their pituitary function because they can end up having hypophysitis. So it's these things that you need to look out for. But for the most part, these agents are absolutely well tolerated. They do not cause chemo-induced side effects. Thus, Nivo and Pembro are now FDA approved in patients with relapsed refractory Hodgkin. The one thing that really is very intriguing in Hodgkin is that the paradigm with which we know how immunotherapy works does not apply to Hodgkin. So, in the world of solid tumors, we do know that anti PD-1 therapy works by enhancing the CD8 T cell recognition that's presented by the MHC class 1 molecules on tumor cells. But in 95% of Hodgkin lymphoma cells, they have decreased or absent cell surface MHC expression. So that's a conundrum that was finally solved, knowing exactly well why patients respond that well to PD-1 inhibition in Hodgkin lymphoma. PD-L1 is almost universally expressed 100% on Reed-Sternberg cells as a result of amplification of a chromosome called 9p24.1. And this amplification causes expression of the PD-1 ligand, which eventually causes immune evasion. It also causes increased JAK-STAT signaling, which eventually causes increased PD-1 ligand expression. So we can certainly target this with inhibitors and therefore PD-1 inhibition. And in some clinical trials, JAK2 inhibitors have also shown excellent efficacy. So AAVD is now the new standard of care. We do know based on certain excellent phase 2 studies that AVD plus nivolumab has an overall response rate and a CR rate of 100%, and nearly 95% of patients are in a remission at the 2-year mark. So intuitively, you would like to bring them forward. And thus, this is the birth of the SWOG 1826 study, which is enrolling and open at CU and randomizes patients to either AVD plus nivolumab for 6 cycles or AVD plus brentuximab, which is the existing standard. My patients who have been randomized to AVD Nivo have so far had absolutely no side effects. Now, COVID is always something that we have to be careful about, but they have been able to tolerate their treatments well, and happy to report that all these patients are in a complete response at their end of treatment assessment. So, do PD-1 inhibitors work in other lymphomas? And the answer is yes, they do work in non-Hodgkin lymphoma with 9p24.1 alterations. And which are these? These are primary mediastinal B-cell lymphoma, CNS lymphoma, testicular lymphoma, NKT cell lymphoma. Brad Haverkos, my lymphoma partner who leads the T-cell lymphoma program, had an excellent investigator-initiated trial that completed enrollment. He presented the data, which was chemotherapy plus nivolumab. Patients did well. And on the right side, you can see one of my patients with primary mediastinal B-cell lymphoma with a large mass in the mediastinum, which actually went on to have partial response. You can see some of that black tracer still remains on the MIP image and continues to be in a partial response. He remains on treatment. So with regards to mediastinal gray zone lymphoma, this is a gray zone lymphoma in the sense we don't even know what's the best way to spell it. Is it GREY or GRAY? Not quite sure. But what a gray zone lymphoma is basically features of Hodgkin and diffuse large B-cell lymphoma. They actually do not have a good prognosis. You treat them like diffuse large B-cell lymphoma, but patients who relapse, we don't have many options. So this is my patient, 82-year-old female with stage 4 BE, so B symptoms, extranodal sites, with mediastinal gray zone lymphoma. She went through 6 cycles of R-EPOCH, had progression of disease, then got brentuximab, had progression of disease, then got gemcitabine for 2 cycles, progression of disease, got radiation and had progression of disease. And this is where we were flustered. And that's when we did know of certain preclinical papers that talked about 9p24.1 amplification in this subtype of lymphoma. I went ahead and I gave her nivolumab, and her PET scan was finally a complete response. She did have pneumonitis, for which Dr. Lara helped me manage her. At this point, happy to report she has achieved 5 years of remission. I'm not sure if she is cured, but she's off of therapy for 5 years. This is Bobby Flexer. She has told me it's absolutely fine to say her name out loud. She has run a marathon recently, and she's still doing absolutely well. And Bobby actually said that, you know what, you must put my case up to the New England Journal of Medicine. And I said, you must be crazy. And that's when I met my then mentee, now colleague, Dr. Ajay Major, who came in to look for a project. And I said, you know what? This is the patient's request. We'll submit it to the NEJM. The NEJM came back to me and said, we have two other patients exactly like yours, and we'd like to make a marriage of these three patients and publish the report. And we indeed did. Response rate of 100%, CR of 100%, durable remissions over 5 years. So now if we have a patient that walks in through the door with gray zone lymphoma, we do know that if the frontline chemoimmunotherapy does not do well, that immune checkpoint inhibitors will actually work. So moving forward with immune modulators, I won't spend a lot of time on this, but lenalidomide is an immune modulator. It's not chemotherapy. It basically works on the microenvironment of the lymphoma cell and makes it less susceptible to ongoing proliferation. And at this point in time, lenalidomide plus rituximab was compared to rituximab alone in patients with relapsed follicular lymphoma, and progression-free survival as well as overall survival was statistically significant and superior with R square is what we call it. So this is a regimen that we often give our patients with follicular lymphoma. Now let's deep dive into cellular treatment. This is Emily Whitehead, the first patient who ever got treated with chimeric antigen receptor therapy, continues to do exceptionally well and is doing well without disease. So what is a CAR T cell therapy? Chimeric antigen receptor is basically a synthetic receptor that is manufactured in the lab, which takes the ability of using the specificity of a monoclonal antibody to the cytolytic power of a T cell. So you can technically make a CAR against anything. However, the biggest burden in the world of lymphomas are patients with relapsed diffuse large B-cell lymphoma, because once they relapse, their outcomes are actually pretty dismal. And not everyone can be taken to a transplant. And this is where CARs made a huge splash in terms of their efficacy. But CARs didn't really happen overnight. This has been the labor for almost 3.5 decades. The first generation CAR, as you can see, did not have the blue little rod there, which is the co-stimulatory domain, which the second generation CARs do. First generation CARs were efficacious, but they were not persistent. As a result, the durability of CARs were very, very small. And therefore, currently, what is in clinical trials is second generation and third generation CARs. What is FDA approved is second generation CARs, and we use a lot of them. But the logistics is definitely an uphill task. We definitely have to first pherese the patient, and then CAR manufacturing takes in the lab about 3 to 4 weeks. In order to get pheresis, we have to activate a huge, huge team. There was one day that I had a lot of time on hand, and I was looking at the number of personnel that's required to activate someone to be able to go through CAR T cell. And it ended up being 123 people, starting with my intake nurse navigators, then to my lymphoma nurse, then to my CAR T nurse, and then the whole changes started. Data coordinators, infusion nurses, you have infusion docs, you have apheresis nurses, insurance people who really fight tooth and nail to get patients approved for CAR T cell therapy. So it's really something that I wish can become less labor intensive, but the fruits of it are very sweet. So this is my patient with refractory diffuse large B-cell lymphoma, enrolled on one of the CAR T-cell trials that were open at the University of Colorado. After 90 days, you can see the 20 centimeter mass in his abdomen has completely resolved, and he remains in a complete response. These are currently the 3 FDA-approved CAR T-cell therapies, and at the University of Colorado, thanks to the leadership, we were able to actually enroll a lot of patients on Lysocell. That's the construct that we have been using a lot. It has a co-stim domain called 41BB. The co-stim domain matters. If you have a 41BB domain, it goes in slow, it plateaus, and that is why you have less toxicity. If you have a CD28 co-stim domain, it goes in really fast and high, and therefore patients can experience CAR T-related unique side effects, which are all manageable, but that's something that we see higher in patients with a CD28 construct. Overall response rate, complete response rate, was unheard of previously with any other treatments that were being explored. And thus, the FDA approved CAR T cell therapy for patients who had failed 2 lines of treatment in aggressive large B cell lymphoma. The depth of response matters. So at the day 90 mark, if you're a complete response, you can see that a plateau is beginning to emerge. And this is the 5-year overall survival with Axicel, one of the CD28 constructs. And the 5-year overall survival is now 42%. Can we use the word cure? I'm itching to, but I believe we just have to continue to follow these patients. So they do well in the third line setting with CAR T. So, what is the current algorithm for patients with relapsed refractory DLBCL in the second line setting? Usually, if patients are transplant eligible, the idea is to give them more chemo that they have never seen. And this chemotherapy is about 3 times more toxic than R-CHOP. If they respond, meaning show chemosensitivity, then you take them to conditioning chemo, which is 7 times more toxic than R-CHOP, and then give them their stem cells back, which is the autotransplant. Now, clearly, not everyone is made for that based on the functional status. Not everyone is chemosensitive. And with an autotransplant, there is a cure rate of about 30%, which means there is a high burden of DLBCL that can either just not respond to chemotherapy or relapse after an autotransplant, wherein with the FDA constructs, now CAR T cell therapy can salvage 40% of those patients who would have otherwise historically succumbed to their disease. Now, we also know within the cohort of these cohorts, there are certain patients who are even more high risk, where an auto transplant is literally just, you might as well just keep giving chemo instead of taking them to an auto. You can see that primary refractory disease, which means disease that just doesn't respond to R-CHOP, or disease that responds but relapses within 12 months after frontline R-CHOP, the complete response rate for anything that you can do for these patients is only 7%. Median overall survival is only 6 months. So that became the new unmet need at that point. This is when I will go back to my case. So the patient received 6 cycles of R-CHOP and within 8 months developed new lymph nodes again. Biopsy confirmed relapsed diffuse large B-cell lymphoma. What was the next step that we went forward with? We referred the patient to our clinical trial, which was open at the University of Colorado. And one of the trials that was open here was the Transform study. The idea behind these 3 randomized phase 3 clinical trials, which were presented at ASH last year, were to identify the high risk refractory and relapsed diffuse large B-cell lymphoma patients and then randomize them to either getting chemo followed by an autotransplant versus take them right away to CAR T-cell therapy. Happy to report that the first 2 studies, which is ZUMA-7 and Transform, which we participated in and ended up being the lead investigators, were positive studies. We eventually were able to show that a median follow-up of just 6 months, the event-free survival on the standard of care arm was 2 months versus 10 months on the CAR T-cell therapy arm. So this is a comparison between the 2 studies, and as you can see, with ZUMA-7, which uses the CD28 construct, the grade 3 cytokine release or neurotoxicity, which is seen in patients with CAR T-cell therapy, was slightly higher, albeit manageable, as compared to Transform. On the Transform studies, we enrolled a lot of patients. Some of our patients actually got CAR T in the outpatient setting. And at this point, the big question was, will CAR T-cell therapy based on these 2 studies replace autotransplant in CR2 for high-risk relapse refractory large B-cell lymphoma? The answer is yes, because the FDA approved Transform, which is lisocabtagene maraleucel, as of June 24th, 2022. So today, if a patient walks into my clinic with primary refractory or high-risk relapse DLBCL, my intent will be to take that patient to CAR T-cell therapy and no longer offer them autologous bone marrow transplant. So at this point, we have now had multiple CAR T constructs that are FDA approved in several different types of lymphomas. We definitely have liso-cel, axi-cel, tisa-cel in the third line setting. We now have axi-cel, liso-cel in the second line setting. We also have axi-cel and brexu-cel that's approved for follicular lymphoma and mantle cell lymphoma. Mantle cell lymphoma is certainly an extremely difficult lymphoma to treat. And it will take another 1 hour to talk about it, but we are improving outcomes in mantle cell lymphoma, which was previously unheard of. But it's not all glory. We have to deal with toxicities and certain issues. So what are the toxicities that we're really dealing with? Financial, economic toxicity, absolutely. Also, we don't quite know which are these patients who will or will not respond. So when I say 40% of patients are going to have long-term remission, we don't have predictive tools to find out. Besides the off-target toxicity of CRS and ICANS, which is neurotoxicity, which we absolutely can manage, but it needs a well-oiled machine. As a result, CAR T cell therapy cannot quite happen in a community center still. B cell depletion, which means, a good way to assess that is to send for IgGs. If it's lower than 400, the patient ends up being a high risk for infection. So we empirically give them IVIG if they are post CAR T cell therapy patients. In terms of my team, we have Dr. Stephen Baer, who is really deep diving into bioinformatics, looking at predictive modeling to assess which patients shall we truly take to CAR T cell therapy. And then we have Dr. Jagger Jassam, who is very interested in assessing economic toxicity in lymphomas, particularly CAR T cell therapy. So, in terms of enhancing efficacy, what all can we do? We certainly need to improve. I want a 100% cure for my patients. And what can I do for that? We could either target, instead of just one antigen, we can target two antigens and then treat the cancer. That could be a bispecific or a bicistronic CAR. We now currently have a bicistronic UCD1922 CAR that's open and enrolling for patients with relapse aggressive large B cell lymphoma. We could potentially just decrease manufacturing times. You can imagine if a 3 to 4 week manufacturing time happens, the cancer is not going to wait. So you just keep on giving them chemo after chemo. And if there is a way to expedite that, that'll be lovely. UCD19 is one of those CAR T constructs, homegrown at the University of Colorado, championed by Terry Fry and the Gates Biomanufacturing Facility. The manufacturing times is less than 2 weeks. In terms of what else could we do, we could develop off-the-shelf products where the manufacturing time completely goes away. And that way we can look at donor CARs. So patients who are healthy, wherein we can actually manufacture CARs from them. And then, of course, can we identify tools to take the right patient to the right CAR? And we have our stellar chief resident, Meryl Colton, who did some excellent work in minimal residual disease. She actually presented at ASCO and had an excellent video summary, which is on YouTube for your review. So in terms of what is the new unmet need? In terms of the new unmet need, I can say post-CAR T relapse is now the bane of my existence. And I want to take care of it. Our team wants to take care of it because, as you can see, conventional salvage therapies after post-CAR T failure do not work. Median progression-free survival is less than 2 months and overall survival is 6 months. So, case to be continued. My patient actually enrolled on the Transform study. He was the only one who actually did not do well. He progressed. So how would I treat the patient? Right answer, clinical trial. I sent him to a clinical trial, which was open at the University of Colorado, which was utilizing a molecule called the bispecific antibody. The idea of bispecifics is that you have an antibody with two prongs. One prong sits on the CD20 on the B cell, the other prong sits on the T cell and tells the T cell to kill the B cell. This patient enrolled on a clinical trial that contained mosunetuzumab and polatuzumab. Remember the antibody drug conjugate? And eventually ended up having a fantastic response. This is my patient in North Dakota, doing really well and still in an absolute remission. So what's happening at the University of Colorado? The past and the present have certainly been extremely helpful because we have had a winning streak. And I hope to God that we continue because most of the trials that we opened ended up being fully enrolled and FDA approved. So our patients ended up getting the benefit of the experimental product at least 4 years before other patients when the FDA approved the construct. As I stated, we have homegrown CARs that are being manufactured on campus, UCD19, UCD1922, which is the bicistronic CAR. And then most recently, I also opened something called the AlloNK trial. Remember, we talked about the innate immunity. So that is something that this is really manipulating in order to tackle advanced hematologic malignancies. I want to give you a quick brief on this data that I presented at AACR on the UCD19 study in patients with relapsed refractory B-cell non-Hodgkin lymphoma. It's a feat to say that all of these 7 patients, manufacturing was successful in everyone. There are so many other CARs wherein we send the CARs for manufacturing and eventually get the reply saying the CARs could not be manufactured. That happens in about 20% of our patients. And that is a nightmare to deal with because by then the tumor is proliferating, you don't have a backup option, you're scrambling for clinical trials. But manufacturing on the UCD19 study was successful in all patients at a median follow-up of 1 year. 6 out of 7 patients on day 90 had a complete response, and 5 of those continue to have a complete response. Most of the patients did not have any high-grade toxicity, as in none of the patients had high-grade toxicity. Only 2 patients had grade 2 cytokine release. 1 patient had grade 2 neurotoxicity, and 100% of patients did report a toxicity called boredom. They were extremely bored in the hospital, and I would welcome that. So, in terms of conclusion, I think the field is really rapidly evolving. I have changed this talk over 5 times, at least over the last 2 years. But the idea is to develop better molecules which have improved efficacy, decreased toxicity, with the goal of 100% cure. And I think the only way that we can make this happen is by enrolling our patients on excellent molecules on clinical trials. So I do want to thank you for your time. Thank you so much for this invitation. Also to the leadership that is by Clay Smith and Craig Jordan, who were able to hire me in 2014. I started my first clinic in 2015. I didn't know what I was doing. My dad said, you know what? Think of it as a startup. You'll either do well and stay there or not and come right back home. I'm so glad the former happened. And now, from an N of 1, we are an N of 5 with the most recent recruit, Dr. Major, who is our home child. So, very, very happy to talk about our lymphoid malignancy program and so excited for what the future holds. Thank you so much.
Turn to our live audience for questions first. And while we're waiting for questions, I just want to ask you one myself. If you have someone who fails CAR T therapy, they relapse their disease, what does that disease look like genetically afterwards? Is it the same cancer as before, or is it somehow fundamentally different?
So that's an excellent question, and that's certainly something that we are deep diving into. We do know that most of the cancers that relapse after CAR T cell therapy, they often have a very proliferative biology. The cadence is very fast growing, but then there are some wherein you can actually wait and see what next. It's hard to understand biologically because we don't quite understand the drivers of the mutation yet. And I think this is where some of our research that's happening here will definitely help. Usually what we do is we biopsy the patient. Biopsy is key. At every relapse, biopsy is key. And assess for the CD19 protein expression. It is a send out stain, so it takes a little bit of time. But once we know if the CD19 is positive, we have 2 more molecules that are CD19 targeted. We typically enroll our patients on those. Versus if it's CD19 negative, we are scrambling for clinical trials. Thankfully, at the University of Colorado, we do have clinical trials. At this point, I will have to say within the next 4 months, bispecific antibody treatment is going to become approved in patients with follicular lymphoma. And we do know data that bispecific antibodies can respond in patients with CAR T cell therapy 25% of the times. So I think that probably will end up becoming the next go-to. So hopefully patients end up doing even better.
Dr. Kamdar, thank you. It was a great talk. And I'm glad you're here with us from a department perspective. 2 questions for you. One on CAR T. And specifically, I was surprised at the number of people that are actually involved with. I had no idea there was that many people. Where do you see the opportunity to streamline or enhance the process? We're doing some of that work on campus, as you alluded to, but I'd love to hear more about how we could do better, because I see this as a growing therapeutic strategy, and I worry that we may not have the ability to generate as many CAR Ts as we need for the patients that might benefit from them. That's question number 1. Question number 2 is for the learners in the room. There's a lot of consternation in the academic literature about the choice of endpoints in clinical trials, especially in cancer. You mentioned PFS, you mentioned CR. I'd love some just, maybe ad-libbing on when you choose in your trials a specific clinical endpoint, what goes into your thinking about what would be the best way to do that? Thank you.
Thank you so much for your questions. I'll take the second one first. So in terms of endpoints, when we look at lymphoma, we want to first assess if we are looking at a curable lymphoma or we are looking at an incurable lymphoma. In an incurable lymphoma, I think I am absolutely fine with the progression-free survival. If I can keep someone in remission for 5 years versus 5 months, even if at the end of the day the survival is still the same, because just the biology of the indolent lymphoma is they're going to live a long life, I would consider PFS as a good surrogate. On the aggressive lymphoma standpoint, for example, Hodgkin or diffuse large B cell lymphoma, in order to make a true impact because it's aggressive, you have to demonstrate a survival benefit. Now, having said that, I'm going to backtrack on my own words because Polarix was a positive study based on the PFS endpoint. And overall survival is absolutely similar. But that could be because patients are just getting so many more treatments downline that it's really hard to demonstrate an overall survival benefit at a median follow up of 28 months. But the Echelon 1 study that I showed you with the AAVD versus ABVD, initially at the 3 year mark, there was only a PFS benefit. We quickly incorporated that in our clinic. And just 6 months ago, at the 5 year mark, an overall survival benefit emerged. So, you can wait till that happens versus if the insurance company approves it or if it gets on the NCCN guidelines, then it certainly becomes a lot easier to give. With regards to the first question, yes, I think at this point, a lot can be done with regards to streamlining the process. I will go probably external to internal. If I go externally, I think we need to continue to foster our relationships with our community providers, especially because if I'm saying today that CAR T cell therapy has replaced auto transplant in high risk relapse refractory DLBCL, I need that call from the community provider the minute he or she is suspect of a relapse. I cannot be getting that patient when the patient is thriving with tumor. And because in order to get the patient to apheresis, I need at least 16 days. That's the median. Because in order to get a patient to apheresis, I have to activate these different teams. So this is where there is another bane because we are growing well, but with that comes growing pains. So we certainly need more staff, we need more space. We are not able to put in more than 5 people on the apheresis machine because we just don't have as many. We don't have scheduling, we don't have resources. We need a larger cancer center to be able to accommodate that many people. Number two, we need our insurance authorization providers to be able to really fight the fight and get this approved faster. I cannot tell you how many times my lymphoma nurse and my lymphoma nurse coordinators are just on the phone, racking their brain for hours on end, going from one provider to the other, 5 times over to be routed to the same provider again and going over the same history. But I will tell you, my team is so amazing that they do it. There was one patient who, after an initial denial, took 2 months to get him to CAR. His scars didn't manufacture, which is such a pity. And then we kept him going with something, thank God for that. And today he got his scars back and he got admitted for lymphodepletion. But that is a village that makes this happen. And at the cost of sounding sappy, I do believe if my team did not have the heart in it, this would just not happen. So it is teamwork. And I truly believe in that. In terms of so I opened my soapbox, but I do have to continue. I think we definitely need more people. For example, there are certain insurance providers that we cannot even see at UCH. So when a patient wants to see me, they cannot. They have to pay out of pocket. So in order to streamline all of that, there are just so many levels that we can make it better. Besides the biology part of it, where we can work on decreasing manufacturing times, we can work on making enhanced efficacious products. All of that is certainly going to be on us and we are at it. But the peripherals is something that sometimes is beyond my pay grade. And it's hard to tell the patient in clinic that I'm really sorry, I cannot take you to CAR T because your insurance declined it.
Oh, thank you so much, Dr. Kamdar. That was a really hopeful talk. Makes me feel better about that. So we have a couple of online questions. So the first one is, do you have any data or thoughts about CAR T and Hodgkin's lymphoma? And if so, is that available at UC?
So that's an excellent question. And Hodgkin lymphoma, relapse Hodgkin is thankfully not high in incidence. As a result, we do have to strategize which CAR T clinical trials we will open and will not. if we have a robust and even more robust community provider network that can send every relapse Hodgkin to the university, then I think we can open that trial. But to your point, a CD30 CAR is available, and CD30 CARs have the principal investigator is Natalie Grover from University of North Carolina, Chapel Hill, and she has presented some excellent data, good response rates, especially in patients who fail brentuximab, nivolumab, pembrolizumab, because that's the line, right? And now if you bring them up front, you have lesser options going downward. So that's where I think we definitely can do better.
Thank you for a lovely talk. I have a completely naive question. What is the difference between cure and remission and progression-free?
That's great, actually. That's a great question. So cure basically means that so in the world of lymphomas, we use the word cure for aggressive lymphomas. We very rarely use the word for indolent lymphomas. And we typically say someone has been cured if they continue to be in a complete remission for 5 years. So at the 5-year mark, we use the word cure. And in terms of progression free, it basically means you are free of cancer for as much time in terms of the PFS. So if your progression free survival is 10 months, that means for 10 months you lived cancer free.
We do also have another online question. So here, what is the average time for CAR availability? And do you have any experiences you can share about losing a patient before CAR is available for them?
So I think I just did in terms of a few patients, but in terms of the availability, that's certainly something that we need to improve on. But if we look at Axicell, the FDA-approved construct, that's the fastest. The availability turnaround is 17 days. With Lysocell, it's about 34 days. It can be sooner, but that's usually what happens. And now what's happened is the FDA has approved it, and these companies that hold these constructs are not able to support that much demand. So we're not able to find apheresis slots in order to send the cells to the company. So there are some additional challenges that have surfaced. And what was the second question? A story in terms of so I will have to say, thankfully, there are not too many to share because we do have clinical trials that we can get our patients on. But we are all realistic oncologists. At the end of the day, we value quality of life. And I think when a patient gets to a point that too much is enough, I think that's when we definitely say this is it. The biggest challenge for me is when I know that a CAR T construct has the potential to cure this patient 40% of the times. And I have to say no, either because the manufacturing failed, or the manufacturing takes forever and the cancer just proliferates, or the insurance company declines, or if I don't get a timely referral to be able to do these steps in a timely manner. And I would absolutely say there are many, many patients like that in my clinic where you have to look them in the eye and say, sorry, just cannot help you. We should end it on a positive note, though.
I'll ask a question I think can end on a positive note. So you talked about, cure in many of these diseases being 5 years without obvious disease. You showed dramatic pictures of people who are disease riddled, and then they get pembrolizumab and the disease goes away and you stop the pembro at 2 years.
Mm-hmm.
I don't know that I'd want to stop. How do you know when to stop these drugs that are so incredibly efficacious versus keeping people on even longer therapies? And is that a trial design decision?
Absolutely. I think we just followed clinical trial design. On the clinical trial that led to Pembro and Nivo approvals, they were given forever, but there was a decision wherein if the patient maintained a complete response at the 2-year mark, they were able to get off of it. So when you do that, it is a really big conversation because there are not too many numbers that I could quote. There are half of those patients who stopped continued to be in a remission, half of these patients fail. However, what we do know is that retreatment works. So therefore, I think there are times when my older patients, and I have to use that word cautiously because I'm getting there, but my older patients are now able to say, you know what, I'll just remain cancer therapy free. I know if it comes back, I'll respond. But my younger patients, especially the AYA population, that's a more difficult conversation to have. because you have them go back to college, they want to do bigger, better things, and then the cancer comes back, and that's because you stop the drug and you have to now get them back to the cancer clinic. So I think those are some of the challenges.
It's great. Well, it is 1 o'clock, so I want to say thank you for your time and thank you for that really excellent talk.
Thank you so much.
Thanks, Manali.